So, ionic common entrance surgery, one by one I am going to discuss the various questions. So, first question, what is the Tilloch sign in mesenteric cyst? So, very simple straightforward question. The answer here is A. So, the answer here is A, mass is mobile only in perpendicular plane to mesentery. So, let me explain you what is this. So, what is Tilloch's sign? So, you all know very well, the root of mesentery is in this direction, it is attached like this, the root of mesentery. To this only the entire mesentery is attached like this, and to this only the small bowel is attached like this. So, the root of mesentery is only 15 centimeter length, and we have a 600 centimeter of bowel attached to this, and cysts arising from this mesentery are known as mesenteric cyst. Cysts arising from this mesentery are known as mesenteric cyst. An interesting point about the cyst is these cysts will be moving perpendicular to the mesentery like this. They cannot be moved horizontally like this. In this direction we cannot move. So, if there is a cyst here, I can move it perpendicular to the mesentery. So, the movement perpendicular to the mesentery is known as Tilloch's sign. Movement perpendicular to the mesentery, number one, it is known as Tilloch's sign. Point number two, I would like to tell you, there will be central dullness surrounding resonance. So, this is 3 together is known as Tilloch's triad. Please don't forget, that is known as Tilloch's triad. If they ask you only Tilloch's sign, go with this perpendicular to the mesentery. Movement perpendicular to mesentery is known as Tilloch's sign. Tilloch's triad is central dullness surrounded by resonance. So, this is the first question, very simple, straightforward question we have discussed in our app workbook. So, please remember this question, first question. So, second question, very simple question. 25 years female patient presents with progressive dysphagia for solids and liquids. Barium swallow was done. What are the investigations needed to confirm your diagnosis? So, from this picture, what do you think this can be? This is undoubtedly an achalasia. I don't know why some students are answering as rat tail. This is not rat tail. This is a typical bird's beak appearance you are seeing here. In this image, what you are seeing is a bird's beak appearance. There is an abrupt cutoff, bird's beak appearance. Apart from that, you can think from the age itself. It is 25 years female, means very young age. So, young girl, 25 years female will get a typical condition, that is achalasia cardia. So, for achalasia cardia, the investigation of choice is esophageal manometry. So, please don't forget, answer is endoscopy with esophageal manometry. So, coming to the third question, which of the following are components of Q SOFA? Q SOFA, what is Q SOFA? Q SOFA is a quick sequential organ. So, quick sequential organ failure assessment score. Sequential organ failure assessment score. So, it is known as Q SOFA score. Please remember, it is Q SOFA score, known as quick sequential organ failure assessment score. This is based on 3 factors. Royal Challengers Bangalore. The mnemonic is Royal Challengers Bangalore. Respiratory rate, confused status, and low BP. So, BP less than 100 millimeters mercury systolic, respiratory rate more than 20 per minute, and altered sensorium, all are given 1 point for each. So, 1 point, 1 point, 1 point. If the score is more than or equal to 2, there is 10% mortality. So, this scoring is used mainly to predict the mortality in sepsis, septic shock. So, Q SOFA is a score used for septic shock. Please remember that point. It is used for septic shock. We use this Q SOFA. So, it is a very clear-cut, straightforward question. The answer here is A, B, C. Respiratory rate, blood pressure, CNS features. So, this is another baby question. What is the size of cannula shown below? You cannot miss this type of questions. 14 gauge is orange, 14 gauge is orange, 16 gauge is grey, 18 gauge is green, 20 gauge is pink cannula. Picture shows you a pink cannula. Name this position of patient in the operation theatre. It is a clear-cut position of a reverse Trendelenburg position. The head is up, leg end is down. Head end is up, leg end is down is reverse Trendelenburg position. We use this position for thyroid surgeries, any surgery on parotid. In all these cases, we make the head up so that there will be less bleeding from the top side. So, head up is done for these patients. So, reverse Trendelenburg or a Trendelenburg position. So then next question, based on the COVID things going on now, this question has come. This is actually a microbiology question, just I put it here. In the following conditions, sanitizer can be used. So please remember, I have to put the sanitizer before examining the patient, and after examining the patient I will put the sanitizer, and after touching the patient's things, any things I have touched that also may contain the COVID virus, so I should put a sanitizer. And only thing which will not put sanitizer is when the hands are soiled, my hand is full of blood or some already contaminated, I will first wash with the soap water. I will first wash with the soap water, then only I will put the sanitizer. So if at all the answer should be A, B, C or A, B, C, D, I hope the microbiologist will clear this. So I have given in following conditions sanitizer can be used. Better answer will be A, B, C or straightforward answer, but even after hand soiling also, after washing with the soap and drying our hands, we will put sanitizer, that also we do. So let us see any guidelines given, and based on that we will get the answer soon. So 25-year-old male patient came to emergency department with a history of trauma. His respiratory rate is 35 per minute, BP is 100/60, on percussion hyperresonance is heard over the right side heart. So fast was performed by the doctor in the emergency room and is normal. After looking at the chest, what is the next step of management? This is a case of pneumothorax. So fast was performed, it is normal, but chest X-ray very clearly shows there is an intention pneumothorax with the mediastinal shift is seen. So please don't get confused, it is a clear-cut question. All pneumothorax, first we will put wide bore needle in the 5th intercostal space. But immediately within half an hour we will arrange ICD tube and immediately we will put an ICD tube. We will not keep the patient roam with only the needle. We will immediately put a needle. So by the needle the gas is coming out. Within few minutes we will arrange and put an ICD. So best answer here will be B. Wide bore needle followed by intercostal drain in the 5th intercostal space is the perfect answer. So this is a picture showing you which of the following symptoms are seen in the child with the following X-ray. So the red arrow is showing a single bubble appearance. Where will you get? So where will you get a single bubble appearance? Newborn baby with a single bubble appearance seen in congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. Double bubble appearance. So double bubble appearance seen in duodenal atresia. Triple bubble appearance seen in jejunal atresia. So single bubble appearance congenital hypertrophic pyloric stenosis will have non-bilious vomiting. These two guys will have bilious vomiting. That is a classical difference. Bilious vomiting. So single bubble congenital hypertrophic pyloric stenosis, double bubble duodenal atresia, triple bubble jejunal atresia, multiple bubbles in midgut volvulus. Multiple bubbles are seen in midgut volvulus. There will be multiple bubbles seen. So please don't forget single bubble, double bubble, triple bubble, multiple bubbles are the findings seen in various appearance. This is a case they have put you a patient with the single bubble appearance. Please remember the answer for this is not non-bilious vomiting. There will be palpable mass. The congenital hypertrophic pyloric stenosis will be found as a palpable mass. A visible mass arising from left to right is also mentioned in the choice. Actually, though I have mentioned only palpable mass, they have mentioned the left to right a mass is seen. That is nothing but visible gastric peristalsis. Hypochloremia, hypokalemia, metabolic alkalosis seen. So except for bilious vomiting, all are seen. Which of the following can be used to stop esophageal bleed? So the first one is a picture showing you a clear-cut case of triple lumen Minnesota tube. Second one is Sengstaken Blackmore tube. The third one is an endoscopy. The fourth one is showing you a banding being applied. So these are all can be used. All this can be used to arrest a esophageal varices. So esophageal varices are nothing but dilated columns of veins in the lower end of esophagus. Here there are dilated columns of veins the lower end of esophagus due to cirrhosis with portal hypertension. Cirrhosis with the portal hypertension, the varices are seen like this. So in emergency condition, we will put two types of tubes, either a Minnesota tube which is having a 3 lumen or a Sengstaken Blackmore tube which is a 4 lumen tube, or we will go for an endoscopy. We will use it for banding or for coagulation. Endoscopic banding and coagulation are the two methods used. So in banding we have a special apparatus which will apply the rubber bands into the varices, which will apply onto this varices. So this is a pictures of, in your picture all are mentioned. I don't know whether there is any other scope mentioned, but it is an endoscopy will be usually 100 centimeter with a banding and coagulation can be done. Okay, with a banding and coagulation can be done. So match the following. This is a very simple question. I don't know why this type of questions are being asked by the by the AIIMS Institute examiners. So first one is a ET tube, second one is a Riles tube, third one is a Eurobag, fourth one is an underwater seal, underwater drain. How to differentiate Eurobag from an underwater drain? Actually, you can see this is a third one. Third one is showing you an underwater drain. You can very closely observe the underwater drain. The tube is going up to this place. Up to this place we will fill with water. So this fourth one is a Eurobag. So actually this answer is 1 is A, 2 is B, 3 is D, 4 is C. So this is Eurobag. This is underwater drain bag used for pneumothorax cases. A girl presents with continuous dribbling of urine and she also has fullness of bladder when she voids, which she voids. So she is having continuous dribbling of urine and also she passes urine in between. That means there is normal filling up of bladder is seen since birth, and also there is small amount of dribbling of urine. What do you think the answer will be? This is a case of ectopic ureter. The rule mentioned here in this picture is Wiegert-Meyer rule. The rule which is explaining here is Wiegert-Meyer rule. This is the kidney. This is a normal ureter which is draining into the bladder. Okay, this is a normal ureter draining into the bladder. There is one more ureter, that is ectopic ureter, coming up like this, going like this, and this ectopic ureter will usually open in the vestibule of vagina. They open in the vestibule of vagina. So therefore it is seen distal to the external urethral sphincter. So therefore these girls will have continuous dribbling of urine coming from this ureter, and from this ureter the urine coming will be collected in the bladder and the bladder will be filled. So the patient also passes urine in between. Filled bladder urine also will come and there will be dribbling of urine also seen. This is a classical picture of Wiegert-Meyer rule. This is known as ectopic ureter. No doubt in that question, it's an ectopic ureter. 35-year-old male patient of peptic ulcer disease came with a pain abdomen for 2 days duration and obstipation for 2 days. X-ray abdomen erect was shown, that is showing an air under diaphragm you are seeing in this picture. When there is air under diaphragm, no more discussion, we have to do laparotomy and we have to do IV fluids. So IV fluids and laparotomy are the answer for this question, B and C. So answer is 1. So B and C is the answer for this perforation. A 40-year-old male patient underwent cholecystectomy. Post-operatively she is complaining of abdominal pain. What test is performed to identify the bile leak? So the best answer here is ERCP. Don't get confused. The best answer here is ERCP. I'll tell you, there is a classification of ERCP. ERCP classification of bile duct injuries is known as Strasberg classification. So ERCP is the gold standard. ERCP is the most sensitive. ERCP is the ideal one because in ERCP I can also put a stent. I can treat the bile leak. So best answer is ERCP. MRCP can be used, CT scan can be used, everything can be used, including HIDA can be used. But what is best? ERCP is best. With ERCP, we have in fact a classification known as Strasberg classification. The type A, this is type A leak. The cystic duct, I have put a clip, no, that clip has fallen down and the bile is leaking out. So this is cystic duct blowout. It is known as cystic duct blowout. In B, this is an aberrant duct. This is an aberrant duct. This is B, in which there is an aberrant duct. This aberrant duct is clipped. This aberrant duct is clipped. So B is aberrant duct clipping. Aberrant duct clipped is known as B. It's a right aberrant duct which is clipped, no leak. In C, the same aberrant duct is cut. This aberrant duct is cut. So there is therefore a bile leak. Aberrant duct is cut, so it is a bile leak is seen. In D, there is a lateral injury seen. This duct is injured laterally. In E, the duct is injured circumferentially. So in both these cases, there is bile leak. So in which Strasberg classification there is no bile leak is In type B, aberrant duct clipped, no leak seen. C, there is a leak due to aberrant duct cut. D, lateral injury, there is a leak. Circumferential injury, there is a leak. The most common among all this is cystic duct blowout. So please remember, therefore ERCP is the gold standard to diagnose bile duct leaks. What is the additional benefit of doing an E fast? So it means they are asking what is the use of this E. E is extension. Abdominal only we were doing last decade. We will do at epigastric region, we do at left hypochondrium, right hypochondrium, and in the pubic area, in the pelvic area. So now we have extended to the chest. So the chest trauma can be identified is answer for this. Chest trauma can be identified. So most common retroperitoneal tumor is a very basic UG question. It is liposarcoma. Most common retroperitoneal tumor is liposarcoma. 40-year male, a known case of varicose vein on examination, eczema and lipodermatosclerosis was found. It comes under CEAP, clinical, etiological, anatomical, pathological classification of varicose veins. C1, C2, C3, C4, C5, C6. C1, the diameter of the vein is less than 1 millimeter. It is known as telangiectasia is seen. So the diameter is 1 to 3 millimeters. That is known as reticular veins are seen. Reticular or thread veins are seen. C3 is more than 3 millimeters. We call it as varicose veins. Varicose veins actually comes under C3. C4, A is eczema and pigmentation. B is lipodermatosclerosis. C5 is healed ulcer. C6 is active ulcer. Very simple classification. C5 is healed ulcer. C6 is an active ulcer. Please don't forget this. So the answer here is D. A 45-year-old female patient presents to us with a breast swelling of 4.5 into 3. So it is T2. So T1 is less than 2, T2 is 2 to 5 centimeters. So it is T2. Is felt in the left upper quadrant of the right breast, which is not fixed to pectoralis muscle, not fixed to chest wall, no skin changes, single node 2 into 1.5 centimeter is palpated in the right axilla, no mass is felt in the opposite breast. What all investigation will you do in this patient? What all investigation we do? So this is a classical case of early breast cancer. I'll tell you this is an early breast cancer. This case is showing you T2. T2 means the tumor is 2 to 5 centimeter. There is single node which is N1, it's a mobile axillary node. So T2 N1 will come under stage 2A. So stage 2A is a early breast cancer. So for a early breast cancer, the investigation we will do are the following. We will do triple assessment, that is mammography of both breast. We will do true cut biopsy of the lesion, and we will do clinical examination, radiological examination, pathological examination done, and no need of PET CT because it is a early breast cancer. They won't have spread, they would have not spread long. So no need of PET CT in an early breast cancer. So the answer will be, I will do only mammography and true cut biopsy and I will plan for surgery. That is answer for this case. So no need of PET CT for this case. So please remember there is no need of PET CT for this case, only mammography and biopsy of the breast mass is enough. So no need, there is no protocol to do FNAC from the node. If there is a node palpable, it is a metastatic node only, we should go for axillary dissection. So just now I discussed the 18th question, bile leak from an aberrant right hepatic duct that is not communicating with the common bile duct comes under which Strasberg? It is type C Strasberg injury. So 40 years old female had a massive enlargement of her left breast for 15 days. Actually the question was mentioning 15 days. It is mobile over the chest wall. It is locally raised, locally warmed. What is your diagnosis? No doubt at all it is an inflammatory breast cancer only. There is no other suitable choice there. Inflammatory breast cancer can present with a warm enlarged swelling. Within 15 days it can present as a warm enlarged swelling. Please remember this. A patient with head trauma was intubated due to low GCS. Eye opening not seen, verbal no response, no movements on pressure. NCCT was performed, it is normal. So this is the catch point. A GCS is 3/15, patient is in coma. NCCT normal means the only available option is diffuse axonal injury. Can you tell me diffuse axonal injury? Diffuse axonal injury, the investigation of choice is MRI. Very poor prognosis. As per European Hernia Society classification, incisional hernia at the level of umbilicus is known as M3. This is a new question. This is the only new question in surgery. All other questions are repeat questions only. Or repeat question or repeat area. The only new question is C is M3. Please don't forget C is M3 is the only repeat question. So subxiphoidal M1, epigastric M2, umbilical M3, infraumbilical M4, suprapubic M5. Please don't forget these are the various midline incisional hernias. Midline incisional hernias. Okay. So regarding the boundaries of laparoscopic anatomy of inguinal hernia, they have asked now. Let me explain you the boundaries of inguinal hernia laparoscopic anatomy. So please understand, this is a scrotum. I am seeing the patient from above. This is inguinal ligament. And this is posteriorly iliopubic tract. And this is the peritoneum which is coming up from inside. This is the peritoneum which is going from inside. And this is a deep ring. You can see the deep ring. Into the deep ring, the vas deferens is entering like this, forms one medial boundary. Vas deferens form one medial boundary. Gonadal vessels, testicular artery and testicular vein together forming the lateral boundary, and this is known as triangle of doom. Triangle of doom bounded by vas and gonadal vessels. So the next triangle, this is known as triangle of pain bounded by gonadal vessels and iliopubic tract. Bounded by gonadal vessels and iliopubic tract. This is containing external iliac artery and external iliac vein in the triangle of doom. This is triangle of pain. Pain triangle contains lateral cutaneous nerve of thigh, anterior cutaneous nerve of thigh, genitofemoral nerve, femoral nerve are the nerves seen in this triangle of pain. So these are two important triangles we deal with while keeping a mesh. While keeping a mesh, we keep the mesh in the myopectineal orifice of Frouchard. Myopectineal orifice of Frouchard. Frouchard is the place which is going to cover all the openings. For example, it is bounded by rectus abdominis. It is bounded by rectus abdominis on the medial side, bounded by iliopsoas muscle on lateral side. I am seeing from inside. I am seeing that Frouchard from inside. Iliopsoas muscle in this thing, and this is pecten pubis inferiorly. Superiorly by conjoint tendon muscles. Conjoint tendon muscles. All the openings like direct, this is direct hernia, this is indirect hernia opening, this is femoral hernia opening, and this is inguinal ligament. All these openings are seen in this area, and I will keep a mesh in this like this. I will cover all the hernias by keeping a mesh in a laparoscopic repair. So now you answer this question. Medial boundary of triangle of doom is vas deferens, true. Lateral boundary of triangle of pain is iliopubic tract, true. Myopectineal orifice bounded above by internal oblique and transverse abdomen is true. Myopectineal orifice bounded by iliopubic tract inferiorly is wrong. It is bounded by pecten pubis inferiorly. Please don't forget this anatomy. This question, this image is not the exact image which happened in the question, but the answer is correct. 13 years, young girl with the left side neck swelling, history of slow growth since childhood, hard in consistency. So with that girl had, the image in that exam had some freckles and macules in the face. So it is a neurofibroma. The tumor is neural tumor. Very simple, straightforward question. It's a neural tumor. Match the correct answer related to the nerve injuries. Breast surgery, we have long thoracic nerve bell injury. Thyroid surgery, external laryngeal nerve injury. Submandibular gland, hypoglossal nerve injury. And thymectomy, we have phrenic nerve injury. Thymectomy, we have phrenic nerve injury. So very simple, straightforward. So in thymectomy, the most common nerve injured is phrenic nerve. 60 years old male presented with severe abdominal pain. On examination, his BP is 90/60. Pulse rate is 112. History of multiple vomiting episodes is seen. Pulse rate is irregularly irregular. On examination, his abdomen is soft. Bowel sounds are absent. Your diagnosis is what? So this is a classical case of mesenteric ischemia. I will tell you why I am telling you this is mesenteric ischemia, because in this history, if you see, the patient is having clinical features of atrial fibrillation features are seen. Pulse rate is increased. The bowel is having some problem. Whereas bowel sounds are absent, abdomen is soft. So these all classical features of acute mesenteric ischemia. So in acute mesenteric ischemia, there are signs out of proportion to the symptoms. Signs out of proportion to symptoms. So please remember, in mesenteric ischemia, the signs are out of proportion to the symptoms. That means when the patient will be having a soft abdomen, but the vitals, everything will be abnormal. Next day, the patient will have a guarding abdomen and the patient will be having no pain at all. So patient is, in this history, you can see patient is having severe pain. Pain is severe, but abdomen is soft. When you go next day, the bowel has gone for gangrene. The abdomen will be having guarding, but the pain will be absent. Pain will be absent. Please remember this point. This is a typical feature of acute mesenteric ischemia by itself. It's an MCQ. What is the most likely cause of this picture shown here? It is an ulcer seen in the foot. It is a neuropathic ulcer. Please remember, it is a neuropathic ulcer shown in this image. Neuropathic ulcer. 35-year-old male chronic smoker came with a complaints of, came to OPD with a right calf pain and ulcer over the grade 2. So there is an ulcer over the grade 2 and he is a 35-year-old male chronic smoker. What is your diagnosis? Diagnosis over. He is a case of thromboangiitis obliterans. We have to confirm there is infrapopliteal lesion on both sides by doing various investigation. They are asking what is the next you do. They didn't ask you the investigation of choice. They are asking you what is next. So the answer next is duplex scan. The next investigation is duplex scan. The gold standard would have been digital subtraction angiography, but they asked next is duplex scan. So 25-year-old female presents with rapid weight gain and loss of appetite, has very low T4 and high TSH. So very low T4, high TSH is a case of hypothyroidism. Hypothyroidism is classically seen in Hashimoto's thyroiditis. It's a picture of Hashimoto's thyroiditis. So these are the various questions asked from INA common entrance test in surgery.